pathways for sustainable financing for cancer care in Nigeria, translating strategy to action. My name is Dr. Ann Adaogo, and I am the Director of Policy for Private Sector Health Alliance of Nigeria. This afternoon, I would be guiding a series of conversation around how we can translate strategy to action when we talk about mobilizing sustainable financing for cancer care in Nigeria. I have the privilege of working with distinguished gentlemen and ladies who have made significant contribution to sustainable financing or improving health outcomes in Nigeria. And this afternoon, they will contribute to our body of knowledge on how we can turn the searchlight on financing for cancer in Nigeria. I believe that this is a timely conversation as we work to translate strategy into concrete action. The urgency is clear. Globally, cancer accounts for about 20 million new cases and 9.7 million deaths as of 2022, with the sharpest rise expected in low and middle income countries, for which Nigeria is part of. Across Africa, we have over 1.1 million new cases every year, and mortality remains disproportionately high due to late diagnosis and limited access to comprehensive care. The story is no different in Nigeria as we mirror this burden. Between 2018 and 2022, the country recorded close to 269,000 cancer cases. In 2022 alone, we saw 127,000 new cases and nearly 80,000 deaths, numbers that represent real Nigerian families that face financial hardship, emotional strain, and often preventable loss. Most of us who are sitting in this conversation today have either been infected or we are affected by cancer. We all know someone or a family that has been affected by cancer. Yet, these health realities collide with a challenging physical landscape, government revenue constraints, competing national priorities, and a global decline in donor funding, which means that the traditional public financing is no longer enough. And it is on this premise that the National Cancer Intervention Fund has come to life. And this is a very critical moment for the National Cancer Intervention Fund. The National Cancer Intervention Fund offers a new pathway, one that mobilizes federal and state commitments, leverages private sector capital, and attracts support from development partners, the diaspora, the academia, and the media. Across such models in Africa, building on examples like Rwanda's cancer care and Kenya's radiotherapy expansion, we are able to show that it is possible that through partnerships and political will, financing can be possible. So today's conversation is about applying these lessons that we have learned across the globe and across Africa, practically, sustainably, and at scale to our situation in Nigeria. As I said in my opening conversation, we have an exceptional panel today where every sector is represented. Their perspectives will be essential as we chart a finance model that is inclusive, accountable, and future-proof. Distinguished ladies and gentlemen, I welcome you to what promises to be an exciting 1 hour of conversation around sustainable financing for cancer care in Nigeria. It is on this premise that I'd like to invite the chairman of the National Cancer Intervention Fund, no other person than Dr. Gafar Alawode, as I popularly call him, the Otumba of Public Health, to give us a framework, a premise for the National Cancer Intervention Fund, the strategic framework. It will be a short presentation that leads us up to the panel discussion that we will have this afternoon. Over to you, Dr. Gafar.
Thank you very much, Dr. Han, for the introduction, and thanks for the new chieftaincy title that you just bestowed on me. I highly appreciate it. Good afternoon, good morning, good evening, everyone, depending on where you are, and you are welcome to this webinar. On the I'm going to be building on the foundation laid by Dr. Han for this. I hope everybody can see my slide. So, as introduced, my name is Gafar Alawode. I chair the National Cancer Intervention Fund. Before we start the webinar panel discussion, I would like to take you through a few things that we have already done as National Cancer Intervention Fund using this outline. Building on the background, we know in terms of non-communicable disease, generally the body of the disease is shifting. Uh, mm, so I just want to confirm if my slide is changing. Okay, somebody else will project for me. Uh, But as I was saying, as we are still trying to get it right in terms of technology, the burden of disease is changing generally. We're having non-communicable diseases accounting for a larger proportion of disease burden, and of course, accounting for a third of all death, which cancer is part of that non-communicable disease. But if we are looking at the cancer body, is rising generally in Africa, including Nigeria, and it is projected that by the year 2030, the burden of cancer will actually double. And this is in the context of a weak cancer care infrastructure, underfunding, and the poor access to cancer care intervention. So, and of course, a lot of deaths, I think, from the available documentation, uh, Nike was more than 2,000 of cancer being delivered, discovered every every year, and only very half of them have access to um, cancer necessary intervention. Next slide, please. Okay, so as we are still trying to get to the next slide, so of course, government is trying its best as much as possible to provide necessary resources for cancer funding, but the available fund can only take care of only very small proportion of people that need it. So we have the Cancer Health Fund that was introduced by the government, but the available resources at the disposal of Cancer Health Fund can only take care of a very small proportion of people that have cancer in Nigeria. And if you look at people that have, and then the Cancer Health Fund is designed to take care of uh, breast cancer, prostate cancer, and cervical cancer. And from the slide that is being shown here, even if you use if you use all the resources, if you use all the resources to take care of either breast or cervical cancer or whatever, it's going to take care of only a very small proportion, as we can see from the slide here. Next slide. So again, if you look at a burden of cancer, spending on cancer is catastrophic to all income group. What does this mean? Irrespective of the income group you are in Nigeria, whether you are the rich, the poor, you know, if you have to spend money out of pocket to take care of cancer, is beyond what is called catastrophic threshold. By the time any spending on health is hit 10% of household income, would tag that catastrophic. So that is what you are going to see from what you can see from the charts. The next slide. So, so this leads us to why the National Cancer Intervention Fund was actually established. for a number of reasons, like I said earlier on, rising cancer burden across Nigeria. Cancer care is unaffordable, especially if you have to pay it out of pocket, and existing government fund is not is grossly inadequate. That was what led to formation of National Cancer Intervention Fund by the National Cancer Society, and it was inaugurated by the Honorable Minister of State in July this year. And the Cancer Intervention Fund was established to ensure expansion of cancer care services, to ensure there is a capacity to address cancer treatment, and of course to mobilize resources for research. Next slide. So since the inauguration of our National Cancer Intervention Fund in July, the National Cancer Intervention Fund has actually swung into action, engaging key stakeholders. The first port of call was NICRAT, which is responsible for treatment, and they are the custodian of the Cancer Intervention Health Fund, to be able to hear from the horse's mouth what are the challenges, what are the gaps. Of course, we visited the service provider, the National Hospital, and as part of our engagement, as we visited the Sovereign Wealth Fund to have a fruitful conversation with them. Then the Honorable Minister looking at what are the opportunities locally and in diaspora. We had an engagement with reputable Nigerians abroad in terms of forging collaboration on that. Of course, we set the stage for the retreat of National Cancer Intervention Fund, where we had a retreat, to articulate framework for resource mobilization. So, as part of our retreat, we clearly articulate um, resource mobilization framework and resource utilization a framework. And as part of our resource mobilization framework, we look at mobilizing resources from different sources: public sector, private sector, external innovative financing mechanism. Don't forget, the National Fund is of mobilizing billion naira to support cancer care programming in Nigeria. So, as part of the public sector financing as well, we look at mobilizing resources of course, in terms of our resource mobilization strategy, we look at mobilizing resources from public financing, private sector financing, and external financing. And for public financing, we look at how do we ensure that federal government spend more, state spend, LGA spend, how do we mobilize private sector resources, and how do we mobilize resources from our partners and donors as well, as much as possible, to ensure that we are able to mobilize adequate resources. So in terms of our public sector strategy, at the federal level, like I said earlier on, don't forget that we have the Cancer Intervention Fund. Part of the objective is to ensure that government put more resources on this, and the money is not only allocated, but is released and well executed. And then we are looking at other sources like earmark sources. We are very active engaging. The other time we were in the National Assembly to look at sugar sweetening tax. We are at the forefront of clamoring for, allocating sugar sweetening beverage tax for cancer funding, and of course, to look at other means from the federal government as well. At the state level, we came up with what we call 100 by 37, which we are looking at each state each year spend at least 100 million naira on cancer care, ensuring that they have benefit package they have a budget line for cancer care. And we want local government to at least spend 10 million, what we call 10 by 774, to spend at least 10 million on cancer care. And we're working closely with Algon on this. So, for the private sector, engagement, of course, we are looking at working with the philanthropist corporate organization, and we want to work closely with Private Sector Aid Alliance of Nigeria to mobilize the private resources. We are looking at leveraging corporate social responsibility from private sector, and of course working with having a sort of bilateral arrangement in terms of public-private partnership on equipment lease and other possible ways the private sector can spend more on on cancer implementation. And in terms of innovative financing as well, we are conducting a landscaping to look at to make informed evidence-based advocacy for cancer care. And then, of course, looking at having a summit sometime next year where we are going to bring the private sector together, where we're going to have an engagement and have a strong pathway for sustainable financing for cancer care. And of course, we are looking at opportunity in diaspora as well. The Cancer Intervention Fund, in collaboration with Nigeria Cancer Society under the leadership of Honorable Minister of State, is in discussion with a number of our diaspora organizations. One of our diaspora partners here, we have Dr. Miriam from Germany, all the way from Germany, participating, and we are looking at partnership with diaspora partners in the UK, in Germany, South Africa, and other places as well. Next slide. So it's not only about how to mobilize resources. We are looking at effective way of resource utilization as well. So we have developed a resource utilization strategy. First and foremost, to look at what are we looking at? How do we want to spend, mobilize money? So we are looking at all cancers, because Cancer Health Fund is looking at the main prevalent cancer beta. Of course, we are looking at all cancer, paying attention to prevention, awareness creation, and of course, early detection and management, and a very, very careful selection criteria to ensure that the people at most are actually the one that benefit using the vulnerability selection criteria. So in terms of where would resources we go into, of course, treatment and diagnosis, because cancer is very, very, very catastrophic. But at the same time, paying attention to prevention, as 30% of money will go there. And of course, using 15% of the money for capacity building, while palliative care and M&E, we account for 10% of our mobilized resources. So this is done to minimize the burden of cancer treatment for the Nigerian. So in terms of governance structure, we put in together a governance structure for the money that we are going to mobilize from the governing council itself, at the facility level, at the level of cancer intervention fund, have a committee that will ensure identification of prioritized patient to be supported. And of course, the disbursement committee that will look at disbursement of funds, and monitor evaluation committee that ensure that we're actually reaching the targeted vulnerable population, and we are monitoring the outcome. It's not only about mobilizing resources. We want to ensure that people that are receiving this money are having better health outcome. And they want to take advantage of technology as much as possible. Based on the understanding of the current situation, we look at some challenges that technology can help us to overcome. In terms of if the process is manual, how do we have electronic registration? If we are losing patients due to follow-up, how do we have a digital care coordination platform to ensure effective navigation? Because part of what discourage patients are saying, even accessing the care, if the navigation at tertiary hospitals is very cumbersome, it could discourage them. And then, of course, we are looking at a digital payments gateway, which we improve on the existing system. And then, of course, a dashboard and real-time analytics tool that will tell us from time to time how are we doing, are we meeting our targets, how are the patients faring as much as possible. Then lastly, this is a call to action, what we want each segment of the society to do to help us achieve our objective. For government, of course, we want collaboration, we want government to do more beyond what they have already done to ensure that we're able to raise more money, but not only that, to raise the accountability bar for investment at the state level. We want our 100 by 37 to work, where all the states will contribute 100 million at least, and then create a budget line for cancer and expand the fiscal space. And of course, our development partners, of course, to work closer with us. We are very grateful to WHO. In the last, they have providing support in terms of in the area of analytics, helping us with technical assistance. We want more partners to come in and provide necessary support, mobilize our resources as well. Of course, we are confident that we are going to work closer with the private sector. We have leaders of private sector health alliance in the room. We want to work close with them to ensure that we have the private sector organization on our side. And of course, our Nigerian diaspora, we have started the conversation. We want to build on that so that at the end of the day, we achieve the entire objective. So on this note, I would like to thank you very much for listening to the overview of our strategy. And I wish you happy deliberation. At the end of the day, we assure you that all strategy we work on, we are going to translate them into action. Thank you very much. And thank you, Dr. Han.
Thank you very much, Dr. Gafar. And this is what you get when you have a chief mobilizer and a chief convener in charge of any group of people. Dr. Gafar is the chairman of the National Cancer Intervention Fund, and he has continued to provide leadership to ensure that the mandate for this particular group or task team can be achieved. Thank you very much, Dr. Gafar. This would lead us into the panel conversation this afternoon, where we're going to be spending about 25 minutes. And this is also to encourage members of the audience to put their questions in the chat box because we will have 10 minutes to address these questions. We cannot have this array of experts in the room and leave without asking them some of the burning questions. We may not be able to exhaust completely all our questions, but as much as it's possible, let's engage with them and see how far we can gain in terms of knowledge. So permit me this afternoon to introduce to the team or to the audience, Professor Abidemi Omonisi. Professor Abidemi Omonisi is the president of Nigerian Cancer Society. Please let's make him feel warmly welcome. A round of applause for him. Please send your reactions in the chat box. Thank you very much. Following him closely is Dr. Ahmad Abdul-Wahab. Dr. Ahmad Abdul-Wahab is the Executive Director of Programs and Partnerships, Nigerian Governors Forum. Let's make him feel warmly welcome. We also have on this distinguished panel, Dr. Mia Ngon. She's the team lead and health promotion for disease prevention and control, World Health Organization. She's in the Nigerian country office. Please, let's make them feel warmly welcome. Keep sending in your applause. And this has my personal bias. I'm pleased to introduce Dr. Tinuola Akimbolagbe. Dr. Tinuola Akimbolagbe is the Managing Director, the Chief Executive Officer of Private Sector Health Alliance of Nigeria. Round of applause for her, please. Following her closely is Dr. Ladi Hamid. Dr. Ladi Hamid is the General Manager of Roche. Let's make him feel warmly welcome, Roche Nigeria. And the mommy of the House, Chief Mrs. Mojima Kanjuola. She's the chair and convener of Nigerian UHC Forum. She's also the Chief Executive Officer of International Society of Media in Public Health. You're very warmly welcome, ma. And then my last introduction on this expert panel is Dr. Miriam Adamu, who is the president of Nigerian Medical Association in Germany. So we can see that we have an array of experts in the room today who will touch on every aspect of the strategy as outlined by the chair of the National Cancer Intervention Fund. You're welcome, distinguished panelists, and I would like to go with the first question to Professor Abidemi Omonisi. Professor Abidemi Omonisi, can you confirm if you can hear me?
Perfectly, I can hear you.
Okay, so I'd like you to share with us an overview of the burden of cancer in Nigeria and some of the strategic actions that the Nigerian Cancer Society is taking to address these challenges. I know I had put out a couple of statistics when we started, but it will be nowhere near as detailed as what you have. So if you can quickly share with us what the burden of disease is, and some of the strategic actions that your society is taking to address these challenges. Over to you, Dr.
Thank
Omonisi.
you so much for having me. One thing we can not shy away from is that the burden of cancer is certainly increasing in the country. More Nigerians are coming down with cancer, and the pattern has not really changed over the last 3 decades. When we're in medical school, we see cases of advanced cancer, and that's what we're also seeing, as far as practice is concerned in date. So majority of our patients still present with advanced cancer, and the traditional cancer is still there. Breast cancer for more than 2 decades, being the most common cancer in female, followed by cervical cancer. In males, we have prostate cancer also, topping, the group. But what is more disturbing, is the change in the epidemiological pattern in terms of age. In the past, individual age 50 and above, you think they have chronic illness, you think of cancer and some other chronic disease. But we find out that younger people are coming down with cancer, particularly the youth. Three cancers actually are very prominent in that age group in Nigeria. We have breast cancer, we have colorectal, hematological malignancy. So the pattern has particularly changed. And, cancer like lymphoma, for example, are not what we see often in the past. But non-lymphoma is also very important. In fact, it has climbed up to second most common cancer, and some places third, among the males. So you can see, the pattern is actually changed. The body is increasing. The pattern is actually changing. And in children also, many years ago, Burkitt lymphoma used to be what we think is the more common cancer among them. But in the last 2 years, we set up a specialized pediatric cancer registry there in Lutz, Lagos, and we reviewed the outcome just earlier this year. Found out that leukemia have taken over. So the pattern of cancer keep on in certain group. And
so we understand now that the pattern is changing and that the age group is also evolving. So we'll be happy to know about two strategic actions that the National Nigerian Cancer Society is taking to address this challenge.
One most important thing that we cannot share away is data, because data, drives science. Data, also important for national cancer, program. Our cancer registration have suffered serious setback, since inception 50 years ago. And one thing that we have done is to work with relevant government agencies and families of faith to strengthen cancer registration, in this country. And now we have more population cancer registry and distribution. In the past, the reference point used to be UCH Ibadan, but the cancer registry data is being used to project for the entire country. We know that distribution where individual lives also have a lot of play, a key factor in the occurrence of cancer that you see. And we have seen that since we have more registry. So we have more population of cancer registry, they are strengthening, but most importantly, the children have been abandoned, over the decades. Most of those registry are, basically adult registry. They do little about children, but now, we have the first population of cancer registry, with the support of the Nigerian Cancer Society, Prime Minister of Health, and Lagos United Hospital, we have to set up one in Lut.
So
And
in addition to improving our cancer registry and our use of data to support implementation of cancer programs, what other steps have you taken or has the society taken to address this burden of disease in Nigeria?
Yes, one other thing we have done is to bridge the gap between the federal and the states. The truth must be said, the federal government have done a lot in the cancer space in the country. Where we have issues at the state, I work on the subnational level. It will interest you to know that there are states in this country where they have no, cancer control plan. In fact, they have no decks for cancer control program in the state. So what we have done in the Nigerian society is to now have state branches, because we have this excellent collaboration in Federal Ministry of Health. In fact, there is no policy on cancer in this country that we are not there. If NCIF is not there, it's unlikely, that policy will be rectified. So we are part of all national policy that have emanated in this country on cancer. So we think that one way for us to bridge that gap, between the federal and the state, is for us to have branches. Now, as we speak, we have Nigerian Cancer Society in all the all the 36 states in the country and federal capital territory. And the mandate is very clear to the chair, that they must work very closely with the State Ministry of Health. What we've done, our national mapping, in terms of oncological services at all the state level. We know each state. We know state without clinical oncology, for example. We have state. We know state without state cancer program. So we are trying to assist the states, work with Prime Minister of Health. Where there is no program, we are trying to assist them to set up program.
Oh, thank you very much. Yeah, so thank you very much, Professor Monisi, for laying the ball for me to ask the next panelist. We have heard about the disconnect between the federal and the subnational level. And the next person I'd like to engage is in a good place to speak to this. So, Dr. Ahmed Abdul Wahab, can you confirm if you can hear me?
Hi, good afternoon. So Dr. Ahmad is not available. I'll be representing him. My name is Dr. Fatima. With the Governors Forum. I can hear you.
Thank you very much, Dr. Fatima, for being here. So we have heard from the president of the Nigerian Cancer Society how important it is for the subnational to mirror or to contextualize the national level at the subnational level. So from your perspective, I know that the National Cancer Intervention Fund has a proposal that looks at 100 million Naira annual commitment per state and 10 million per LG, the 1077 for a plan. What's your perspective? From your perspective, what political, economic, and governance incentive, what do you think can encourage the governors and local government chairmen to commit to this?
Okay, can you hear me? Just confirm.
Loud and clear, Dr. Fatima.
Good afternoon once again, and thank you for having me. So really, when it comes to the governors and the local government chairman, I think one of the most important thing for them is to make sure that whatever proposal we're taking to them makes sense. And it has to make sense from a political perspective, from an economic perspective, and from the governance perspective. Now, in terms of that, we can incentivize these things in various ways. One, as far as the political realm is concerned, I think we have to be able to demonstrate a visible impact on citizens' lives. We all agree, and as the chairman also said in the opening remarks, that cancer really is one of those things that would eat away very deeply at your pocket, no matter how financially sound you are. So because of that, the sheer burden that cancer causes, if we would be able to demonstrate that through these our proposals, through these frameworks that the NCIF is proposing, we would be able to deeply impact on people's lives. I think that's one way to get the political buy-in. Another thing is also there is so much energy that is going towards communicable diseases in Nigeria, especially different treatments, different preventive strategies for preventative diseases, for infectious diseases, but probably not so much momentum is being directed towards non-communicable diseases. So if we're able to even bring that into the conversation, that look, this is also just as important, being champions of non-communicable diseases also would put the leaders in the forefront so that we're able to tackle, because if we're not giving it as much attention as we are to communicable diseases, then we really run the risk of the non-communicable diseases coming and really overflowing, and this is part of what we are experiencing currently. As far as the economic incentive is concerned, the proposal already has brought it out clearly. Each state is to give 100 million and each local government to give 10 million. The fact that the pooling is done together would basically reduce the financial cost, and it would send that message that, this thing, we're all in it together. So no state or no local government has to go through it alone. And this is a Nigerian problem. It's a national problem. So we have that shared responsibility. We could also incentivize the government, the governance and the accountability part. So the NGF in particular is known for scorecards. We do scorecards for various things, for nutrition, for immunization, and for various other interventions that we do. And one of the things that we have noticed over the years is that it really brings about that healthy competition between governors, between governors. So at the subnational level, you're able to in just a picture show which state is doing well and which state is lagging behind, and what they need to do, and it really holds them accountable. So that is also something that I think we can really leverage on.
Okay, thank you so much for those thoughts, Dr. Fatima. And I would leave those thoughts there and I'll come right back to you. Dr. Mayer, from WHO, can you confirm that you can hear me?
Yes, I can hear you.
So it looks like for us to be able to incentivize the government to fund cancer treatment based on Dr. Fatima's submissions, it's important that we are able to provide the data that makes sense, provide a scorecard, and then help to redirect energy from communicable to non-communicable diseases, just to show that these as well is important in the scheme of things. This would require technical assistance and a bit of hand-holding. So what kinds of technical assistance do you think partners can provide? And how do you think that WHO can support the National Cancer Intervention Fund to access such assistance?
Yeah, thank you. Thank you for the question. Yeah, there's a lot of things that we can support, and we can also suggest that please let me start with the WHO, the technical assistance, because the technical assistant we have a different health program that's also include the non-communicable diseases, which also cancer is part of it. So usually we focus on the prevention, detection, diagnosis, treatment, and palliative care. So there are several aspects, and then we have the global guidance, the framework. So the case management guidance, the screening guidance. So the global guidance that we can also help the country to adapt it. So this is also one of the area of technical assistance that we can support. And then another thing is that we can also help the country and the way we did for other health programs. So we have different communicable disease programs every year, every 4 or 5 years that we have the strategic plan development, and then we also have that the operational, the work plan development, these kind of things that we looking at the situation. So that's how we start to support the health program. So that is also the area that now we are supporting the Cancer Intervention Fund. We will be looking at how the situation, what is the burden, how many partners are supporting. So this area we can also provide the technical assistance. And then there are also the technical specialists in different organizations that we can also see the mapping. So which area the strength of each organization, then we can also split the task, role and responsibility to provide the assistance to the country to make this intervention fund and the implementation, make it happen. So then, yeah, these are the technical assistance area. Yeah.
So given the way that the National Cancer Intervention Fund is structured now, how do you think they can access some of these technical assistance, both for prevention, for diagnosis, for treatment, and for palliative care? How do we help to develop a work plan that is implementable and that one can translate to the more non-technical people to enable resource mobilization?
Yeah, thank you for the question. So this technical assistant, the technical assistant, this is we need to identify which area that we can we need the technical assistance. So what we can do is that we can also look at because now we will start with the situation analysis, and then we can see which area are required. And then what we can do is that this the first task, what we are supporting is the situation analysis, and then we will also be mapping the technical partner or implementation partner, and we can see how we can provide the assistance. What we can do is that the partner meeting, consultative meeting, and then we can also discuss each other how we can get the technical assistance from one to another. And that is also the consultative meeting. At the conclusion, then we can also mention that we can identify which organization can provide what kind of technical assistance. So we can split the role and responsibility with the partner consultation. Yeah.
Thank you so much, Dr. Meah.
Yeah.
And obviously, from your conversation, it is evident that we need to do a stakeholder mapping so that we can all leverage on each other's strength. And we have quite a number of stakeholders in the room here. One of the major stakeholders or critical gates to unlocking funding for the National Cancer Intervention Fund is the private sector. And I'm pleased to bring on the CEO of the Private Sector Health Alliance of Nigeria to speak to the next aspect of this conversation. Dr. Tinuola, kindly confirm that you can hear me.
Yes, I can hear you, Dr. Ann. Thank you.
Okay. So what models of public-private partnership can we use to strengthen cancer care, infrastructure, diagnostics, and treatment in Nigeria? If you can leverage on some of the expertise that Pishan brings to the table.
Thank you so much for that question, Dr. Ann. As espoused by previous panelists and in the excellent presentation done by Dr. Gafar, cancer is something that is no longer rare in Nigeria, but it does appear that the numbers are underreported. So it's quite obvious that we have a lot more cases than what it is that we see from the statistics that are presented. And this is something that is on the rise. Dr. Fatima said earlier that we're now coping with the double burden of communicable diseases, which had previously been our mainstay of what we were focusing on. Now we've thrown pandemics and epidemics into the mix, and we still have to look at chronic conditions, of which cancer is one. So looking at that, it is something that is quite a priority, and it's something that is evidently going to get possibly worse before it gets better. So what does the private sector bring to the table, and what is it that we can do to provide models that can work with something like this? There are some public-private partnership models that we can use to strengthen the infrastructure in an environment like ours. Prevention and early detection is just as important, as well as treatment and management, palliative care. Looking at the outcomes that we desire and the cost, which is obviously a major factor in a developing economy like Nigeria, early detection or prevention are preferred alternatives. So there's some models that we can look at. We can look at having some type of design, build, finance, operate PPP model where we have regional cancer hubs. I know currently we have something like that, which the NSIA, the Nigeria Sovereign Investment Authority, is rolling out, but implementation has been quite slow. Looking at the concentration of cases both in the rural and in the urban areas, we need to have these regional centers, which would be funded by multiple stakeholders. With the PPP model, we have the states, the state governments, they would provide land, they would provide regulatory support, and then the private partners would design, they would finance and operate these types of centers that feature diagnostic and chemotherapy centers. They need to have long-term contracts. So for some examples that we've had in the past, when we had a change of government, a lot of those contracts become terminated. So we need to have long-term contracts that run into 10, 20 years, which would make the private sector more interested. You can look at what the Lagos State PPP framework has done. That illustrates a little bit clearly the structure and the life cycle management. And this is something I think a lot of other states can benefit from. Then we also have to look at some type of blended finance concession, particularly for things like radiotherapy and other extremely high costing equipment, which are paid for in forex. There need to be concessions, both at the point of import. We need to have concessional grants from DFIs to absorb that first loss risk and then be able to unlock the commercial debt and the equity so that these radiotherapy and other PET and CT scanners, which are used for the management and the diagnosis of these conditions, can be brought into the country. Then we look at service contracts and social franchising. We need to have some type of system where there is blended or cross subsidization, where those that can pay can use some of their funds to cushion the effects of those that cannot. We also need to have some type of central hub and spoke system so that we have accredited pathology labs which serve as hubs, and with telepathology, teleoncology, it's easy to reduce the turnaround time on diagnosis, and this would help to improve the quality of care that is provided.
Thank you so much, Dr. Kimbolagbe, for that. The expose is really insightful in terms of all of the things that we need to do with the private sector to get the train moving along the rail. And one of the major things you spoke about is early detection and prevention. If we can focus on early detection and prevention, we can at least get rid of 50 to 60% of the burden of the cost of cancer management. And I know a major part of prevention and early detection is in diagnostics. And so this leads me to the next panelist, Dr. Ladi Hamid, who is the General Manager of Roche Nigeria. Because diagnostics is one of the key cost elements in terms of management of cancer. So Dr. Ladi Hamid, confirm that you can hear me loud and clear.
Yes, I can, Dr. Ann. Thank you very much.
Okay, so I'd just like to find out from you, what kind of financing models and technology do you think, with the experience of Roche and your contribution to the healthcare in Nigeria and globally, can help to reduce the cost of cancer medicines and improve sustainable access to for patients?
Thank you very much, Dr. Ann. And talking about innovative financing models, I think one of the first things that comes to mind is that in a country and technology, in a country like ours that is so large and vast, we cannot have a one-size-fits-all model when we're looking at cost of financing for cancer care. So we need several interventions, and I think the previous speaker elaborated on quite a few of them. Definitely blended financing comes to mind, where we need a combination of both public and private financing, and we need to be creative about what we choose to bring to the table. We in the past have looked at single-digit loans for different cadres and groups of patients, because we have both the high, middle, and low income. So for some people, single-digit loans would be a possibility for them to pay for their healthcare needs, and then really minimal returns to the financing organizations. We can also look for performance-based financing, where payment is only made based on the outcomes that the patient or the government actually desires for itself and for the outcomes of the ecosystem. We can look at sin taxes and sugar taxes. I know those discussions are already going on. When you look at diagnostic areas, we can do pay for service. Rather than looking for huge cost outlays to pay for equipment, we can look for models that pay per patient, per service. And I think those models are even better for diagnostic organizations. When you now bring in technology into the frame of discussions, today we're talking about AI, and AI can improve efficiency and reduce wastage. Precision medicine is a really big thing today where we can properly target diseases that are affecting patients rather than trying to treat the whole of the patients. We can also use AI to reduce wastage and reduce complications that worsen the outcomes for the patients. Using AI also to remove the redundant parts of drug discovery and actually making the frame and speed of drug discovery significantly faster would reduce the cost of medications that ultimately comes out to the patient at the end of the day. And I think lastly, like said by the previous speaker, telemedicine and remote models of accessing care in a country as large as ours would be something we need to really consider. We may not be able, as she talked about hub and spoke models, we may not be able to have centers in every single place. We need to gradually scale and grow our healthcare system, but trying to do everything everywhere all at once, I think would be extremely difficult. So using digital health and telemedicine would really be helpful in getting the practice right, removing the barriers, and then gradually improving the outcomes that we want for our patients. So those would be my initial thoughts there.
Thank you so much, Dr. Ladi. Very insightful in terms of the hub and spoke approach, and then the use of telemedicine and digital health, and knowing that we cannot have a one-size-fits-all situation for Nigeria. That importance of contextualizing the intervention depending on the geographic area where we find ourselves, I think is extremely critical to this conversation that we are having. Another component of cancer management is awareness, the role of the media. And it's my pleasure this afternoon to introduce and to bring on the next panelist, Chief Mrs. Mojima Konjuala, who is the chair of the Nigerian UHC Forum, just to enlighten us and speak to us about models of media engagement that will be effective in influencing policymakers, because as Dr. Fatima alluded, how do we bring these to the fore that policymakers and people who are in a capacity to provide funding for cancer treatment will prioritize cancer or NCDs as it is with the communicable diseases. Chief Mrs. Mojima Konjuala, can you confirm if you can hear me?
Yes, I can hear you loud and clear. Can you hear me too?
Yes, ma'am. Thank you very much. So if you could just walk us through some of the models of media engagement that will be most effective in influencing policymakers. Most of the panelists here have alluded that we do not have a dearth or lack of policies across Nigeria or strategy statements. Implementation is usually the challenge that we have. And so what models of media engagement do you think can turn this tide around and we move from just talking to walking the walk?
Thank you very much, Dr. Ann. And I'll quickly run through, something that I had prepared. And thank you all other participants online. This is a crucial area for improving public health outcomes in Nigeria. The media, as a result of our huge diversities, ethnic, religious, geographical, and of course, educational backgrounds and social economic status, there is no one size fits all. And I think we have all alluded to that in our presentation. So we must combine as many as it takes to fit our diverse leanings and envision outcomes. The media remains a crucial area for improving public health outcomes in Nigeria. Effective media engagement can bridge the gap between the public need and policy action. Here are some models of media engagement and ways the media can strengthen transparency and accountability for cancer financing in Nigeria, and the models of media engagement to influence policymakers. The most effective models combine direct policy communication with public pressure, often leveraging data and human interest stories. The evidence-based policy priming model. A, this model focuses on making the case for improved cancer financing through data and expert consensus. Strategy, media organizations partner with researchers, oncologists, and health economists to publish investigative reports and data-driven features that quantify the burden of cancer and the economic return on investment of better financing. For example, lower long-term treatment costs, increased productivity. C, targeted output, policy briefs and infographics, dissemination through mainstream media and directly to legislative committees. Influence mechanism, framing cancer financing as an economic imperative rather than just a health issue, compelling budget decision makers to act based on cost benefit analysis. Then the human cost storytelling models. This approach uses emotionally compelling narratives to build public and political will. Centering news reports, documentaries, and social media campaigns around cancer survivors and patients' families. These stories must highlight the specific financial barriers, e.g., lack of universal health coverage and out of pocket expenses that delay or deny care. Now, long form documentaries and frequently used human interest features, especially in local languages. I want to emphasize that, especially in local languages, that can put a face to the statistics. Now, influence mechanism, generating public apathy and moral pressures on legislators, making it politically costly to ignore the issue. This mobilizes civil society and community based organizations for advocacy. The strategic reporter source relations model. This focuses on building capacity and access for journalists covering health beats. Strategy going forward on building capacity. Health advocates and CSOs must actively cultivate relationships with senior health and political reporters and editors because it's not just what the field reporters bring in, but we must have the buy-in of the gatekeepers, the editors. This involves providing journalists with training on budget literacy, how to track and interpret health appropriations, and exclusive, timely, and verify information from official sources and access for journalists covering health budgets. Now, targeted output. Quarterly media roundtables on the status of cancer funds, e.g., what goes to it from, take for example, the Basic Healthcare Provision Fund, or even the National Cancer Fund with access to technical experts, the bottlenecks, the gaps that needs to be filled like yesterday. Influence mechanism ensures consistent, accurate, and prominent coverage of cancer financing, often favoring official news sources and making the issue a routine part of political agenda. So an agenda setting must be involved. The digital and civil media advocacy model, leveraging digital platforms for rapid mobilization and direct engagement, using social media to create accountability loops where citizens can report on the lack of cancer services in their local clinics, connecting community issues to national policy. We're talking about cascading to the subnational. This includes leveraging social media to amplify the demands of patient advocacy groups. Now, using
Thank you
social
so
media.
very much.
Oh my God.
Yeah, thank you
Okay,
so very much,
that's
ma.
about.
I know,
Okay.
I just know that once we've started, it's going to be very difficult knowing the passion, the experience, and the expertise you bring to the field of play in terms of looking at the media contribution for which you have demonstrated in very practical terms how the media can support improvement in healthcare in Nigeria, especially as we look at universal health coverage by 2030. Thank you so much for your contributions. And maybe coming to Dr. Miriam Adamu, who is the president of the Nigerian Medical Association in Germany, and all of the conversations that our panelists have talked about today around prevention, treatment, rehabilitation, early diagnosis, and palliatives for cancer management in Nigeria. From the place where you sit, what do you think Nigerians in the diaspora? The Nigerians in the diaspora are a significant part of our ecosystem, and we would like to know what you think their contributions to cancer care in Nigeria can be, particularly in service delivery, transfer of capacities, and forging government-to-government partnerships. Dr. Miriam, can you hear me?
Yes, I can hear you. Thank you very much for the question, Dr. And can you hear me?
Loud and clear. Thank you.
Yes, thank you. So I would just start by saying that when we talk about Nigerians in diaspora and cancer care, we often think about monetary donations. But diaspora's real value is not just money, as most of us think. It is expertise, systems experience, and institutional influence. I believe that if all the diaspora resources are well coordinated, that we can significantly strengthen cancer control in Germany. I think the most important thing and the way that we can help is by service delivery. We have a lot of specialists, not only in Germany, in the UK, US. We have huge diaspora organizations of clinicians where we have a lot of doctors that can help with in areas of surgical oncology, hemato-oncology, radiotherapy, pathology, and even imaging. We can start by simple things like having a virtual tumor board. This is something that we do here in our clinic with smaller external clinics where we allow other clinicians to present their patients, and then specialists in the university clinic will help like pave a treatment plan. So this can virtually help make decisions that are quite important and are quite specialized without the patients need to travel. There's also a growing field of telepathology, and we talked about, I think someone mentioned like telemedicine, so I would specifically say teleradiology. As we all know, and it was mentioned a lot, the delay in diagnosis and treatment is what costs lives and not just a lack of drugs. So I think if we can use telepathology and teleradiology as a means to speed up diagnosis, we can reduce cancers that present in late stages, and that is what actually burdens the system. I also think that NCIF can coordinate where diaspora delivery services is most needed. So when we're in diaspora, we don't really know what's happening on ground. So NCIF can play a role in delegating or letting us know in which direction to move, rather than just leaving us to do some ad hoc visits. There is lots of people doing lots of things in Nigeria, but it's really just a single impact stuff. So I think that is where a coordination needs to take place. The next point that I would think is capacity transfer, which is even more sustainable than what I talked about. So it's basically training the trainers. And if this is played quite well and not just one-off teaching, then I think it would make a big impact, like skill development for oncology nurses, for pathologists, for radiotherapists. Also, I think it's quite important what we mentioned, the cancer registry and data staff. So you need to know what you're dealing with and where you're putting your resources into. So statistics is extremely important, and maybe that's where the World Health Organization in Nigeria can step in. Like, you need to know what cancers, at what rate, at what incidence, what are the costs of therapy, what's the cost of early detection in order to balance all the funds that are needed. I also
Thank you so much. I'm going to have to, interject at this point, and then to thank all of our distinguished panelists. We have tons of questions in the chat box. I may find all of them. I may not be able to find some of them. So I'd like to thank members of the audience for being so engaging with this conversation. I apologize to you in advance if I miss your question. You can feel free to put the questions directly to our team of expert panelists, and they can directly answer your question. So I'll start from the bottom of the room. And the first question I have here is for Chief Mrs. Makanjuola in terms of so what I'm going to ask the panelists to do is just to write down the questions that have been addressed to them, so that when you give your 1 minute of wrap up, you will be able to address some of the questions, and then you can summarize in a minute, so that we can let people out of here in good time. So I have a question for Mrs. Makanjuola, which says, how do you think civil society organizations can support it just says, how do you think civil society organizations can support? The other question here is, what effort is put in place to ensure that data collected is harmonized and accurate? I think that's a question for Dr. Miriam. And I think then this is also for Mrs. Makanjuola. While media plays a vital role in spreading awareness, we must not overlook underserved communities where media cannot reach. True impact requires bringing information directly to these communities. So I think this is more of a comment than it is a question. Yeah, so I think it's more of a comment. Then this talks about, given the high cost of treatment for all types of cancers, I would like to know how the mobilized funds will be prioritized. Dr. Gafar, this is for members of the Cancer Intervention Fund task team. Then I think this is also for Dr. Miriam, looking at domestication of some international policies on cancer that could give push to or support to LGA's state and federal levels. Okay, then this is for Dr. Fatima. Beyond mobilization, accountability must be the next, I think this is a comment, it's not really a question. Let me see. Then there's another question here. Is there a national data management platform that cancer data can be reported by the private sector? And how can the private sector cancer data be integrated into this platform? I think this is for Dr. Akimbolagbe. What level of research are we into regarding different cancers and the major causes in Nigeria? Then I do not know who has, do we have emergency hotlines where cases can be reported, escalated at state or federal level? Dr. Fatima, I don't know if you have the answers to some of these questions. And so I'd like to stop the questions here. If there are questions that I have mixed out, please put them in the chat box, and please address your questions to any of the panelists. I'm going to go around the room now and get a 1 minute closure from each of our distinguished panelists, and to thank you so much for the expertise that you bring to the room. I do not think that this is a conversation that we can have in 60 to 90 minutes. We will have to do this a few more times. So Professor Omonisi, who is the chairman of the Nigerian Cancer Society, could you please give us your 1 minute wrap up? Professor Omonisi, confirm that you can hear me loud and clear.
Yeah, I can hear you. Thank you so much for the excellent coordination. Well, just to assure our participants that we are collaborating with all stakeholders to ensure that we reverse the increasing body of cancer in the country. And one of the initiatives is the National Cancer Intervention Fund. You can see the panelists, from private sector, media, And that is what we need, to really combat cancer. We need to bring every stakeholder on board and work together in unison, to united to confront this monster that we call cancer. Thanks, Anova.
Thank you so much, Professor Omonisi, for your closing remarks. I'll come over to Dr. Fatima, who is standing in for Dr. Ahmed Abdul-Wahab. Dr. Fatima, could you give us your 1 minute wrap-up?
Okay, thank you very much. Thank you, everyone. So I just basically wanted to emphasize the things that I had already said, and just to also bring to light that the NGF's role mainly is to facilitate, to coordinate, and to advise at the subnational level. Cancer care, cancer intervention is not something that I'm sure affects only one person. It is a collective responsibility, and really the Governors Forum is more than ready, together with the governing council, to do whatever it takes really to drive these sustainable interventions at the subnational level. Yeah, thank you very much for the opportunity.
Thank you so much, Dr. Fatima. Dr. Maya, can we hear from you?
Thank you. Thank you once again. Thank you for organizing this and sharing all the information. What I would like to emphasize is that we will continue supporting the country at the technical assistance and beyond, partner coordination, advocacy, based on this discussion, and as well as we will also be helping the partners, linking with other health programs which is appropriate to support the health service delivery. Thank you.
Thank you so much, Dr. Maya. Your final thoughts, Dr. Akimbolagbe.
Thank you, Dr. Ann. I think civil society can support in quite a number of ways. We can work to support, scale, and convene the relevant stakeholders, the government, the DFIs, the private providers of health, insurers, and the civil society as a whole, so that we can work together to provide a value proposition to the private sector, looking at various options, blended finance, and we must have a way to bring insurance, have a clear NHIS insurance inclusion plan to be able to handle cancer effectively in Nigeria. And I think that's what we bring to the table. Thank you.
Thank you so much, Dr. Akimbolagbe. And over to you, Dr. Ladi Hamid, for your final words.
Thank you very much, Dr. Ann. I think for me, the solution to cancer care financing has to be multi-pronged in terms of its approach. And we have to build on what is currently available. And the previous speaker talked about insurance. That has to be the basis or foundational approach for what we have. And then on top of that, we can bring innovative financing and other innovative models to support the various categories of people who may not be able to afford insurance, but will then need other means of financing. And whatever we do will not be perfect. But the private sector, especially pharma companies, can support in piloting and innovating and testing what works from other parts of the world and bringing that here for us to learn from that and then scale. And you can count on our support for that. Thank you very much.
Thank you so much, Dr. Ladi. And Chief Makanjuola, I'll come over to you now.
All right, then. Can you hear me?
Loud and clear.
Good. All right. Well, my final word will be to strengthening independent oversights, which would include journalists going particularly at the subnational and hard-to-reach area to see the status and write and speak to the status of cancer care, treatment, and prevention. And of course, to be able to analyze and bring to fore the implementation for cancer prevention, treatment, and care in the country. I just want to conclude to say that there are various reliable credible media platforms that are ready to go along with this. We'll look at the Nigerian Association of Women Journalists, the Nigerian Union of Journalists, the Nigerian Guild of Editors, and of course, a majority of online credible publishers and content creators that are ready to walk the walk, to walk the talk with the rest of us. So these avenues are available to amplify and accelerate what we are able to do, especially talking to cancer financing in Nigeria. I thank you very much for the opportunity given. I hope that this conversation would continue, and the media, I can boldly say on behalf of the media, will walk the path with all of us. Thank you.
Thank you so much. And I'll come to you now, Dr. Miriam. Let's get your thoughts, your final thoughts on this conversation.
I think there were two questions. I'll just start with one about what effort is to be put in place to ensure the data collected is harmonized and accurate. I think there should be laws that govern this. So you should be obliged at the local level, local government level, at the state level, and at the federal level to report cancer diagnosis, whether it's the late stage, the intermediate, or just in the beginning. I think that's how you would get your data. And all screening programs that have, of course, positive diagnosis should also be forced to report. And if we start with this, I think we'll have a lot of information that is quite harmonized and accurate. But I think there has to be a law. The way there are laws here for infectious diseases, they are the same laws that are for cancer. So I think the lawmakers have to work on that. There was a second question. I'm not sure if it was looking into domestication of some international policies on cancer. I don't know if this question was for me. I think this was the second question. As far as that is concerned, I think we cannot just take international policies and put them to work for us. I think we have to tailor our own domestic policies. However, we can align them according to the international ones, which have been seem to be working good for the respective countries. So I think that's just all I have to say.
Okay, thank you so much, everyone. Thank you to our audience who have been with us through this period of 77 minutes, I propose. And for our panelists who have done excellently well on this topic, this is not a conversation we can have in just one sitting. It's a conversation that is ongoing and remains relevant to improving the health and welfare of all Nigerians. So I want to thank everyone for being a part of this webinar this afternoon, and I would request that you look out for more information around the operations of the Nigerian Cancer Intervention Fund and the task team and the activities of the task team. Thank you all, and I wish you all a pleasant afternoon. Thank you.
Thank you very much. Have a nice evening, everyone.
Thank you very much. Have a nice evening.
Thank you very much.
Wonderful. Dr. Anne, you're just something else. Good work.
Thank you.
Thank you, everyone. Compliments of the season.
It's not even, it's the one they did on class that. This one that we're just talking.